Okay, welcome everyone. Give you a few minutes to come in and join us in the room, and we'll get started here. So, thank you all so much for being here today and for joining us for session 17. Can you believe it? In our community webinar series of empowerment through education. My name is Julia Wood. I'm the Director of Professional and Community Education here at the LBDA. And today is our much awaited live question and answer session about psychiatric symptoms in Lewy body dementia with Dr. Chiadi Onyike from LBDA's Research Center of Excellence at Johns Hopkins School of Medicine. So, this is something we've heard a lot about, you guys, the psychiatric symptoms of LBD, and the research and from what we hear on our support line are among the most bothersome for families and the most difficult to manage for healthcare providers. And these recurrent visual, auditory, and other sensory hallucinations occur in estimated up to 80% of people with LBD. And they're often accompanied by delusions, which can be paranoid in nature. And then, along with this, people may experience changes to mood, such as apathy, anxiety, agitation, and depressive symptoms. And unfortunately, with this, some of the things we'll talk about today is how these symptoms often are involved with severe sensitivities to the medications to treat them. And so, this can really complicate medication efforts. So, we're here kind of at the tail end of Lewy Body Dementia Awareness Month. But we did want to acknowledge this. And so this month we launched a new course on our Lewy Learning Center called Unpacking Psychiatric Symptoms. Rose is going to drop a link in the chat for that course in case you missed it. In this course, there were 3 lessons presented by experts that addressed all of these symptoms that I just talked about. Psychosis or hallucinations and delusions, changes to mood and personality, and even issues with agitation and aggression. Remember, the Lewy Learning Center is completely free, and all you need to do to access these courses is to create a free account. And so this live Q&A is being recorded and will be added in as the 4th and final lesson in the Unpacking Psychiatric Symptoms course later this week. So we hope that if you haven't yet, you'll go on and check that out. So before I introduce our guest, a few words here about us. So our guest today, as I mentioned, is going to be Dr. Chiadi Onyike. Something to remember for this live Q&A session, he is an amazing medical doctor, but he's not your doctor. So he's not going to be able to answer really specific questions about dosing of medications, or if you're on a certain, schedule or dosing regimen. He can't really make comments to that, but can definitely answer more general questions. And so, just a little bit about us. We are a national nonprofit, and we're dedicated to improving the lives of families living with Lewy body dementia. And we do that really by improving quality of life. And so, we provide comprehensive education like this, and like all of those courses that are free on our Lewy Learning Center. And we deliver compassionate support in our Lewy line, which I'll bring up in a moment here too. I'll go ahead and bring that information up just in case. You can always find our Lewy line support at 1-800 539 9767. You can also email them at support@lbda.org. So now a couple of housekeeping items to help you navigate today's session. Your Zoom toolbar is typically, it'll pop up when you scroll over it. If you're on a laptop or a desktop computer, it's typically kind of on the bottom of your screen. If you're on a tablet, often it might appear at the top of your screen. And you can select slow show captions on your toolbar at any time. And so you can read along and follow along that way. You can also select the resources icon for different links of resources that are applicable to today's talk, and also different downloads, so tip sheets and documents for you. And we have questions prepared today that we were able to take away from that course on the Lewy Learning Center, but we'll also be accepting live questions as well using that Q&A icon on your toolbar. So with that too, we get a lot of questions about how to access the recording of this. Maybe you have to run away, midstream, or you've got something else to do. You can always watch the recordings anytime. You can share them with family and friends on our YouTube channel at LBDA TV. And to simplify access to our webinars, now you can go to lbda.org and you'll see a like a ribbon or banner on that homepage where you can access those upcoming webinars. All right, and lastly, when you leave the session today, a brief survey will appear asking for your feedback about today's presentation. Please take a moment to complete that survey. We're working on our 2025 10. All right, so I'm gonna step out of this. Once again, this is our Lewy line here, and we're gonna find out who is with us. So let me stop sharing screen, and Rose will launch that poll. So curious, who is with us today? Maybe you're a person with Lewy or symptoms of Lewy. You may be a care partner or a former care partner, a healthcare provider. We have a family and friend of someone with Lewy, and then maybe we have some researchers or scientists with us, and then some others. Maybe you fall into a different category from that. So we'll give you a little bit of time here to share. As usual, our care partners are in the lead. If it was a race, they'd always winning, but in so many ways. So we'll give you a few more seconds here to fill this out. Excellent. Looks like it's starting to slow down. All right. Still going though. Excellent. So looks like we've got our care partners are about 60% of our audience today. So this includes spouses. We've got about 20% of our audience are people with LBD or with symptoms of LBD. We've got about 7% of you are healthcare providers. We've got a little over 20% are family and friends of people with LBD. And we've got about 2% are researchers and about 3% are others. So once again, we welcome you all and welcome your questions today too. Okay, and so I can kind of share that and let you see it as well. So we also have another question that we're curious about. Since this course was really kind of based off of information on the Lewy Learning Center, and for those of you that don't know, we launched that program because we did some focus groups and we really heard that you want to be able to engage with education kind of in your own time, in your own way, and share those resources out. So we want to know which courses you have, or have you engaged with the newest course? Did you take that Unpacking Psychiatric Symptoms course before today to kind of inform your questions? So Rose will launch that poll here for us. So I want to see how many of you took that course and how many of you didn't. Yeah, no problem if you haven't or don't plan to, but just knowing that if you want more detailed information on these different symptoms, that is available for you to watch and rewatch at any time. All right. So a lot of you still have that resource available to you. It looks like about almost 90%. You can still go on and watch those lessons and learn more about psychosis and mood changes and agitation. And we've got about 13% of you who did. And those people will be answering your questions first here today. So I'll share these results so you can see that. All right. And then another question, just one more, and then we're going to get going. We'd also like to know what courses you've taken on the Lewy Learning Center. So you get to pick any and all that apply here. We have a course on vision and Lewy body dementia, a course on living well with Lewy, one on another unpacking course, which are kind of these in-depth topics like psychosis and Parkinsonism that have a lot of moving parts. We have a tip jar if you haven't checked that out, where you can submit your questions, and we have our experts record a little video vignette answering it. And then we also have our Unpacking Psychiatric Symptoms course. So we'll give you a second to fill that out. Excellent. Just so you know, we really, work a lot and with these experts to curate this content based on feedback we get from you all. And so we're excited to see that you're taking advantage of some of that content. All right, so it looks like those responses are about done, but still coming in. All right, so we'll go ahead and end that, and I'll share the results with you. So it looks like about almost half of you have watched that Vision in LBD course, and so that was based off of one of our webinars from 2023. We've got about 40% of you have watched the Living Well with Lewy course. We've got about another 40% that have watched Unpacking Parkinsonism, and so that's all about those movement changes. We've got only about 9% of you have gone on the tip jar, so you might check that out and see if there's some resources on there, or maybe it's a place for you to submit some questions that you don't get answered today. And then we got about 30% of you have watched Unpacking Psychiatric Symptoms. So thank you very much. We really appreciate your input. All right, without further ado, I'm going to introduce our presenter now. So Dr. Chiadi Onyike is an associate professor of psychiatry and behavioral sciences at Johns Hopkins University. He is a neuropsychiatrist and clinical epidemiologist engaged in clinical care and research, and has focused on frontotemporal dementias, Lewy body dementia, and other non-Alzheimer neurodegenerative disorders in young, middle-aged, and older adults. He is a principal investigator and co-investigator of research projects supported by the National Institutes of Health, as well as foundation, industry, and philanthropy grants. He was an inaugural director of the Johns Hopkins Research Center of Excellence for Lewy body dementia, and he serves on several LBDA clinical work groups. I served on mine, and I looked at him highly on those. Dr. Onyike received his medical degree from the University of Nigeria and a graduate degree in clinical epidemiology from the Johns Hopkins Bloomberg School of Public Health. He completed psychiatry training at Johns Hopkins School of Medicine and research training in psychiatric epidemiology at the Johns Hopkins Bloomberg School of Public Health, and neurochemistry cell signaling at the University of Maryland at Baltimore. Please join me in welcoming Dr. Chiadi Onyike. Hi, Chiadi, welcome.
Thank you. Thank you. Thank you for that introduction. I almost didn't recognize myself. That was too much schooling.
I was gonna say, I wonder how many years that equals. Can you recall quickly?
Um, uh, Over 10, I believe. Some of it was paid, otherwise I probably wouldn't have gotten to the end.
Absolutely. Very understandable. You guys, I just wanted to point out too that today's question and answer session was really Dr. Onyike's idea. So he was like, a lot of times he said, I think it's one thing to describe symptoms, but people have a lot of questions about these. So he wanted you guys to be able to really get your questions answered. Okay, so we'll start with this first question that we got on the Lewy Learning Center.
Okay.
And so this is a care partner question, and she asked, what should I do when my loved one denies the need for help with things? Like they clearly need help with shopping or different daily living tasks, and they just outright deny it. Any advice?
So this is a challenging question. It's a very common problem. It's a common problem in Lewy body dementia, but also across the different kinds of dementias, Alzheimer's disease, frontotemporal dementia, you name it. Typically, not always, but typically, the people who have the condition are the ones who don't know they have the condition. Some, in the old days, the psychoanalysts would say this was a form of denial that helped them preserve their ego, their self-esteem. I think today we would say that the capacity to monitor oneself and to update one's sense of self with present day information is impaired in most people with dementia. So that the self-monitoring function, we go about our daily business, and we often have a sense of how we've done in relation to a task that we were prepared for, or maybe not even prepared for. But in Lewy body dementia, this capacity to watch oneself in action is impaired. And the ability to integrate feedback to make that assessment is also impaired. So what I would say is that this is one of the situations in which I'd say explaining is overrated. You'll explain it today, and you'll explain it tomorrow, and you'll explain it multiple times in the same day, and you'll get nowhere. Or if you get somewhere, it will be to get yourself frustrated. This is often what happens. It's one thing that I will say is that there's a distinction to be made between having your say and having your way. And this is an important thing to remember. It's okay to let the person who is living with this condition say what they will say and believe what they'll believe. But you can still, but then find ways to get them to do the task anyway, to direct them. I know that this can be easier said than done. Just to give an example, a person is bags packed, and they're ready to go to work. And you might spend quite a bit of time debating this. So maybe you'll convince them the first time, and then they're back to it. Or you could, one example of an intervention that has helped is to drive them around the block or walk around the block and come back. And then the person, and, chat with them as you go along and essentially distract them. And then when you return, they've gone to work and they're back. But trying to convince people with dementia that they have dementia, if they don't see it, and especially if you've, now it's respectable, I think, and it's a respect for a person to explain to them in the beginning, this is what we're seeing, this is what the doctors have said, this is the diagnosis, these are the treatments. But when you've done that, repeating it over and over is generally not helpful, and it's often engenders conflict. So I'd say distraction, making a request, but not couching it in terms of you have a problem, but rather I need your help, or I would like you to do this so that we can do that. And then maybe that is a pleasant activity. Those are the ways in which we recommend for people to get past denial of symptoms.
Absolutely. That's helpful. Thank you so much.
Well, thank you.
Yeah. The next one was had a lot of moving parts to it. And just so you all know too, who submitted your questions to the Lewy Learning Center, the full question was given to Dr. Onyike to give context, but then we've kind of simplified the questions a little bit for just a general audience. But this individual is a person with symptoms of Lewy, and they were wondering if personality changes and recognition of emotion, if changes to that are common symptoms for people with Lewy body dementia.
They are. They're common. They're not as emphasized because, in a sense, they're not as dramatic as the things that make people look for a diagnosis. Being quite forgetful, having hallucinations, having Parkinsonism, especially if the hallucinations are accompanied by delusions or by paranoia, by fear. They tend to dominate the story. And also, the symptoms that are emphasized are the ones that are the loudest, or the ones that define the illness that are relevant to diagnosis. But there are a plethora of other things that come along that make life uncomfortable, even difficult. And problems with emotion recognition are among them. Problems with emotion recognition. Now, that's one aspect. Also, it depends on how early, people go from being well to having symptoms sufficient for a diagnosis, but there's an in-between. And in that in-between, people can have smatterings of different things that don't seem on their face to add up to much, but might eventually begin to interfere. And to the person who is especially attentive and has some insight, I mentioned earlier that many people don't, but some do, and are able to look back and say, something has changed. And, these non-specific symptoms are actually a common reason why diagnosis can get delayed, even misdirected. People get treated for depression because they're having trouble with their emotions. Let's say that there is a transition period during which people might have things that are non-specific, that are not necessarily the signature symptoms of DLB.
Absolutely. Another question that came in that I think is kind of part of that too is someone asked, do you sometimes see loss of empathy for people with Lewy body dementia?
We do. So empathy, just to expand it a bit, in order to have empathy, you have to have a capacity for perspective taking. You have to be able to put yourself in another person's shoes, so to speak, or in another person's experience. You have to be able to mirror that experience perhaps into something similar in your life. So, for example, if you've been bereaved before, you'll have a deeper understanding of another person's bereavement than if you never have, even though most of us will have an understanding of what it means to lose someone, even if we haven't had that experience directly. But if you have, it's a deeper experience. Now, if you have cognitive impairment, your ability to perceive what is going on, to understand its import, to even make reflections, from your own past experience, those things are impaired. So when it's advanced, definitely, I think the majority of people are going to have a lack of empathy. Now, in the beginning, a lack of empathy is less common, but it does occur. It might also occur because people are not paying as close attention. There's, the executive dysfunction and the inattention, they may not be as attentive to what is happening with other people as they ordinarily would be, and that translates to a reduction in empathy.
I think that's such a great point too, is that, a lot of times these symptoms don't happen in a silo, they really interact and kind of feed off of each other too. And
Yeah,
so I'm sure it can be hard to tease out.
yeah, no, it can be difficult to tease out.
Now, another question that kind of, I think, leans off of this conversation is for someone who's really prodromal. So they don't really have a diagnosis yet, but they think they're having symptoms. What psychiatric symptoms are common for people maybe who are early on or haven't had that diagnosis yet?
So for people who are prodromal, and as I mentioned earlier, they may not. One of the things that we know is well established is what we call REM sleep behavior disorder, or what in psychiatry we would call REM parasomnia. Same thing. What it means essentially is that a person is asleep. They're in that period of sleep where they're dreaming. And ordinarily, REM sleep is accompanied by motor paralysis. So when you're dreaming, you're not acting out your dreams. In very early, and sometimes even as early as 10 years before it is clear that the person has developed Lewy body dementia, they have REM sleep behavior disorder, which basically means that they're enacting, sometimes we call it dream enactment behavior. They're acting out their dreams, and that could be verbally and it could be physically, and often it's both. So that's one. It's not specific, I should add, it's not specific to Lewy body dementia, but it's very common. Say more so than it would be for Alzheimer's disease. Another is depression. Well over 50% of people have a prodrome in which depression and or anxiety is present, and it's explained in psychiatric terms, either as a new disorder or as a reaction to the things that life is throwing at the person. It depends on the context, and it often leads to treatments for those conditions. Now, the interesting thing is that sometimes the treatments actually help. And people get better, and then the symptoms come back, and then in time they return, and maybe they now return with some Parkinsonism, and it becomes clear that this is an atypical depression. And then eventually it's clear that the person has something more than depression. Now, that's a situation where we are sort of, in today's world, stuck, because if it looks like depression, we're going to be approaching it as if it were depression. And there's often not much else to go on until Parkinsonism or some other, or hallucinations begin. And that can be a period of years, sometimes as long as 10.
That brings me to,
Sorry,
go ahead.
forgive me. Yeah, there are other things. Apathy, sometimes people become less industrious. They seem to be lacking in energy and vitality, but it's not usually not that pronounced. And people might think, okay, well, maybe they're no longer enjoying their job, or they're nearing retirement, or there's something that's the matter that they're not talking about. And then things develop from there.
So someone had a question in the Q&A too about hallucinations, like kind of when those start. And that varies a lot, doesn't it, person to person?
It varies widely. For example, it can occur during the prodrome. It can occur in a person who already is manifesting depression, and then it might get interpreted in light of depression, or it might get interpreted as perhaps a complication of some medicine they're being prescribed. But it can occur early, and usually and often it's fleeting. It comes and it goes, and it comes and it goes, and it's hard to know what to make of it until it becomes established.
For sure. We even have a volunteer who describes how he didn't realize he was having hallucinations for a very long time because it was so vivid. He would
Mhm.
walk in his garage and he saw mice scampering and running away until one day the mice ran toward him. And he realized that that was not correct. So he feels like he'd been having that hallucination, but it was so well formed that and it fit the scenario and the context, so he didn't recognize it.
Yes, no, yeah. So we hear that often. And the other thing that we hear are things that are not quite hallucinations. The sense that something just darted by in the corner, or seeing objects within objects.
Mhm.
And that comes and goes, and people will just think, oh, well, maybe I didn't take a good look. Maybe I'm a little sleepy.
Mhm.
And then those things don't become more common enough or established enough until the diagnosis is made for people to really recognize it as a problem. So often this is described looking back.
Right. That hindsight's 2020 and no pun intended, but just like, sleep symptoms can interact with the psychiatric symptoms, the visual symptoms sometimes. So is it an illusion or is it a hallucination?
Yes. Yeah.
Can be hard to tease out as well.
Or even waking up from sleep or falling asleep, people might have visual phenomena that might actually even be hallucinations. Now, there are a fair number of people with no condition who see things as they fall asleep, or who see things as they wake up, or who wake up a little confused as to what was a dream and what's real. But these things can become more prominent as people are developing Lewy body dementia. So it can become more common, more regular, more vivid in the prodrome.
And definitely, I mean, what I'm hearing is because a lot of these symptoms can be vague or can kind of mask, is this can be really difficult to diagnose. So, are there certain tests that can help to confirm or explain these symptoms that can be done?
Well, today, so the most important ingredient I would say is the suspicion. If you don't have the suspicion, and sometimes it can be difficult to have the suspicion if the presentation is mainly about depression. Well, depression is far more common, and people are going to be more likely to say, okay, well, if it looks like depression, then perhaps it's depression. The old saying, if it quacks like a duck, then it is a duck. Depression is so much more common, and also far more attractive in comparison. So people are more likely to say, okay, well, this is depression. Let's not go there yet. But if you have the suspicion, for example, if there's REM sleep behavior disorder, if tremors are coming and going, or if you tried a neuroleptic and they got a bit more confused than you'd anticipated, then there are tests today, 2024, that we can do that we wouldn't have been able to do 10 years ago. Skin biopsy, spinal fluid analysis. There's what's called, I think, the SynTap, that that in the prodromal stage, the alpha-synuclein seed assay, which is what SynTap is about 95% sensitive. It's about 90, it's a similar number, 97% or so specific. So you could actually pin down the diagnosis at that stage if you have the suspicion. There's another assay, I think it's skin biopsy. The skin biopsy test is less sensitive, so it will miss about 15% of cases at that stage. Now, so the point being that if it's a negative test, there's some value to repeating it later if there's sufficient suspicion to warrant that.
And a question that we get often, or we had recently at an event we were doing, is that the skin biopsy and those synuclein tests are looking for the presence of synuclein. So it doesn't necessarily tell someone if they have Parkinson's disease, right? Or if they have Lewy. So what other factors would need to be considered to kind of tease that out?
Well, I think it's the clinical syndrome. Um, with Parkinson's disease, generally the manifestations will be in terms of movement, and that will be the case for maybe 10 years. So There are a few people where the Parkinson's disease accelerates faster or is complicated relatively early by cognitive problems. But in general, they are not going to have hallucinations. They're not going to have cognitive problems, at least of overt cognitive problems, until well into the illness. With Lewy body dementia, on the other hand, at the time of diagnosis, we would usually expect cognitive impairments, visual hallucinations. The cognitive impairment will take the form usually of executive dysfunction and memory loss, usually even more than the executive dysfunction, and disorientation. And it will be accompanied by vivid hallucinations in most cases and overt Parkinsonism. And then there's the multi-system atrophy, which is very rare and has a varying presentation. That might include, ataxia, with meaning incoordinated gait, walking like you're intoxicated, and things like that, on top of the Parkinsonism and the cognitive impairments. It's a very rare condition, so I'm not going to try to unpack it here. But those would be the main competitors. And I think on the basis of the clinical symptoms, you would essentially be able to say, this is Lewy body dementia. This is Parkinson's disease. That might be multi-system atrophy.
Thank you. That's really helpful. So we have a question here about disease progression, and we get these, questions a lot. So this person's, asking their sister has Lewy body dementia and has really had a lot of issues with improper medications being given, like Zoloft or Haldol. And so she's wondering if, does some people just have a really rapid disease progression, or if someone's given some of these medications that are maybe not such a good choice and that can block dopamine or do things like that, can that cause a more rapid progression or decline of disease?
So firstly, some people do have a more rapid progression. But the more rapid progression does not necessarily, in fact, it does not usually translate to a broader sensitivity to medicines or a higher sensitivity to medicines. More likely, the person is sensitive to specific medicines and maybe not so much to others. Now, if a person is broadly sensitive to medicines that we typically wouldn't expect them to be sensitive to because they have Lewy body dementia. So, for example, being sensitive to sertraline, which is Zoloft, or to any of medicines that are in its class, so paroxetine, which is Paxil, citalopram, which is Celexa, and so on. That class of medicines are typically not medicines that we will consider a person to be sensitive to because they have Lewy body dementia. But there are people who are otherwise normal, who are sensitive to that class of medicines. And then if Lewy body dementia came along, it could compound things. And so now they have their original sensitivity plus the Lewy body disease imposed problems. And that can make the treatment experience very, very difficult. Now, it's also true that very often when people are in psychiatric care, particularly in the hospital, doctors are moving quickly. The prescribing is happening quickly, and people are being prescribed more than one thing at the same time. I think that's probably the norm. It happens even though it's the kind of thing that in the textbook will say, do one thing and then do the next. When we're saying that, we're really saying, try this for a couple of weeks and try that for a couple of weeks. And that's not what's going to happen in the hospital, because the time they're working with is much shorter. And so people are doing things in a hurry, and they also feel they can take more risks because they're present to observe. But the consequence of that is that people can get 2-3 medicines simultaneously, which is a problem if you're sensitive to more than one thing. And if you're sensitive to one thing, then it can look like you're sensitive to all of them. So the water can get very muddy. I don't know, have I left an aspect of the question unanswered?
No, I think that was helpful. And I think that, the second part of the question will help with a little more clarity too. In that, if, let's say, someone does have some changes due to a medication, right? And they have some decline, are they able to, can those changes be reversed once they go off that medication? Or is that decline permanent then?
We generally would not think of that decline as permanent. It can be dramatic, it can be severe, it can go on for a long time, or at least they could be down, the decline that they've suffered can persist for a long time, particularly if people are prescribing new medicines that do the same thing. So if a person is prescribed haloperidol, which, in the Lewy body world, at least we, the experts, and I'm sure many of you also would say, absolutely not. So if a person is prescribed haloperidol and then you follow that with risperidone, then you're just doing the same thing twice, which is prescribing a medicine they should not get. Risperidone is about as potent in the same ways, in the same receptors that haldol is. In fact, it's more potent than haloperidol in the same places, so it's going to cause the same problems. So you're extending the duration of the difficulty. And often what happens is that the neuroleptic sensitivity syndrome, which will cause confusion, agitation, and the like, is not recognized for what it is. So instead, it's recognized as more agitation. And that engenders more prescribing. Now, sometimes what we recommend is we just say, you know what, let's just stop, let everything wash out. Yes, it's true that their behavior might worsen, but it might very well get better. And if it doesn't get better and everything is washed out, then we have a clear picture of where things are and what we need to work on. Because once you give a person the wrong medicine and they develop delirium, or they develop a neuroleptic sensitivity if they have Lewy body dementia, it can become from that point on very difficult to tell what's what if you keep prescribing.
For sure. And you guys, there's some great resources that we have to help hopefully prevent that. You can download our medical alert wallet card and take that to the hospital with you. It does warn against those medications. Sure, we'll talk some more about hospitalizations in a bit, but some good resources that you can use to help inform your providers.
Yes.
Um, let's switch gears here then. So, sometimes under agitation or some of those behavioral symptoms, inappropriate sexual behaviors can sometimes be mentioned. So this person has a question regarding their loved one who has Lewy and is living in an assisted living or memory care community. And they said he's begun to exhibit inappropriate sexual behaviors such as lewd language, inappropriate comments, some touching, inviting people to touch him. And it's completely out of the norm for this individual. This is something he never would have done. He's currently taking Aricept, and the community and the family are really struggling to address this. So, what can you typically do to address those behaviors or cope with that?
Terrific questions. I smiled when you started out because a number of years ago we studied sexual behavior, what we called improper sexual behaviors in residential care, in assisted living. And we found that there are two kinds, essentially. There are what we decided we would call affiliative behaviors, and then the other, which we called offensive behaviors. So it turns out that a person with a dementia that's sufficiently far along for them to be in assisted living, they may have people who are at that point might not recognize or might mistake one person for another. And so sometimes you see people holding hands and walking, or they have a tendency to sit with the same person to eat, and then every now and then two people might be caught in bed. And they might not necessarily even be doing anything particular, or they might be kissing, and a family member comes by, oh, that's my wife, or that's my husband. You need to separate them. And then you try to separate them, and then they start fighting, and then it's called abnormal behavior. Well, they just don't understand. They don't remember the relationships. They don't realize that they're in a relationship that some people don't want to approve. But they're otherwise, on its face, it's hand holding, it's hugging, it's sitting together and enjoy and wanting each other's company. So those are the things we call affiliated behavior. Behavioral problems like agitation and irritability that came out of those were as common as in the kind of behavior that you described, but mainly because other people were trying to intervene and they were reacting. And if you left them alone and educated everyone around them, then it was fine. Now, the kind of problem you're describing are the sorts we call offensive. They're groping people, they're constantly making propositions. They might even be following people around, and they might be targeting the same person or the same couple of people. Often it's the staff who are most engaged, who are engaged in the most intimate aspects of care, but sometimes it's another vulnerable resident. Um, we we found that the medicines that seem to offer the best prospects for dialing it down were the SSRIs, meaning medicines in the sertraline, Zoloft, Zoloft, Paxil, Prozac class. And in one particularly memorable case, when we prescribed it, he became apathetic. He'd spent too much time in bed, but he was not doing these behaviors. We reduced the dose and try to stop it, and he'll resume the mischief. And eventually the family were like, well, we would rather he not be intruding on other people's lives. Let's just put him on the medicine. And so we had to make that trade-off. But usually one wouldn't have to make the trade-off where the person becomes apathetic. The more common outcome is it dials it down a bit, or it doesn't dial it down sufficiently, and then you have to keep trying things. People have often tried neuroleptics, but in the case of Lewy body dementia, you have to be very careful with neuroleptics, because you might cause like a sensitivity reaction and precipitate even a medical crisis. So it's a very difficult problem to manage. Usually, at least in the immediate period, you have to put them on close supervision to prevent them from acting out.
Excellent. Thank you. That's really helpful. It sounds like a very complex issue that you studied quite a bit.
We did. And we even got to put out a press release because people found it interesting.
I'm sure. You're the saying, you're never too old. So I think that that's something. We have an amazing sex therapist from Israel that we work with the team training course that I do. And human touch and all of that is something we never lose the need for. So I'm
Absolutely,
sure this
absolutely.
is, yeah, it's a big issue. Um, Switching gears again here. So we have a question related to auditory hallucinations. So we think of visual hallucinations a lot, but this person is severely hearing impaired, and they're asking, is that related? So if someone has really severe hearing impairments, does that maybe correlate with more auditory hallucinations?
There's a sense that some people who have a sensory deprivation, whether it's visual or auditory, at times will have hallucinations. But typically, this happens when there's residual function. And in a sense, the ears or the eyes might play on a stimuli that they don't have sufficient function to make out properly. This is especially true with sound, so soft sounds in the environment can become whispers, and these can take on a malicious connotation and cause secondary delusions and that sort of thing. But in general, there isn't a correlation between hearing impairment, particularly when it's severe. The vast majority of people with Lewy body dementia or any other sort of dementia who are hearing impaired will not have hallucinations. And if they do have hallucinations and they're adequately treated, the hallucinations will go away, whether or not they have hearing impairment. So my sense would be that the hearing impairment in this case is coincidental. Now, the auditory hallucinations are atypical, because we ordinarily, as you were sort of alluding to when you were asking the question, we ordinarily would expect visual hallucinations, but not auditory hallucinations. But that is not to say that they never occur. They do. They're usually dominated by visual hallucinations, but at times we see people in whom auditory hallucinations are more prominent.
And I read an interesting research article once and they found that sometimes the auditory hallucinations will become like a soundtrack for the visual hallucination. So it's the person that you're seeing is speaking with you or interacting with you. And it seems like that would even almost, I guess, kind of cement in a way that or give more validation that the hallucination is real if you're seeing it and hearing it.
Yes, yes.
So with that, we have some questions here, some related to auditory, some related to visual hallucinations. So, sometimes loved ones or care partners or friends are kind of brought into these hallucinatory experiences, and they want the validation from their care partner, from their loved one. So how do you think people should respond to that? What's the best way to interact with that?
Firstly, trying to, arguing that they're not real usually will not help. Now, if the first time it's mentioned, you might say, well, it's human nature to say, well, that can't be, or I don't see that. I don't think it's happening. And occasionally, particularly with someone who has insight, that might be the thing to do. So if you know you have a loved one who is counting on you, and to orient them to reality, it can be very helpful to point out that, honey, remember you have LBD, and I think those are your hallucinations. That's the illness doing its thing. But for the majority of people, listening with an empathic ear, understanding that this is real to them, even though you don't see it. And you might say, look, I know you're seeing this. I can't see it, but let's try to ignore it. Or you can maybe even distract them completely. Now, if they're further along in the dementia, it's easier to do the distraction. If it's relatively early, the person might see that you're trying to distract them, and that in itself could become a problem. In which case, just providing reassurance, letting them know that you're here, that nothing that you can see is happening. You know it's real to them, but you're not seeing it. So perhaps it's the illness, and then you blame the illness. The illness is a very good bogeyman. So you blame the illness, you remind them about it, and maybe you suggest a pleasant activity. Let's take a walk. And those are the ways I think we would recommend to deal with it.
Excellent. I had a gentleman one time who loved Fleetwood Mac. And so what he chose to do, he had a lot of auditory hallucinations.
Yeah.
And so he has headphones that he wears and listens to Fleetwood Mac. So
Oh,
that's what he's chosen. And there are times a day that they're not as prominent. And so he'll go away from it. But he felt like he knew that was a hallucination. He knew he wasn't really hearing it. And so he chose to listen to some Stevie Nicks instead. So
yes.
definitely try some different
I have to
strategies
say, yeah.
there.
Yeah. And he had good taste in music as well.
Absolutely, absolutely. So another question here about the medication. So a lot of times, when we're talking about these psychiatric symptoms, we'll see mood interact with sleep. And so we got a question if there are any medications that don't have side effects, which I think right there, I think all medications have side effects to, possibly to some extent, and that can be used for anxiety and insomnia. So anything you're familiar with there?
So firstly, we would say that in general, with Lewy body dementia, prescribing like a cholinesterase inhibitor helps with a variety of behavioral problems. It can help with cognition. And we would say in general, it should be the first line, and it can help with hallucinations. It can help with delusions. It can help with anxiety. It can help with sleep disturbances. However, a person might already be taking that, and it's not, and they still have anxiety and hallucinations. What we've often done is use a low dose of mirtazapine. People may know it as Remeron, and it really can be very helpful for sleep. And sometimes, if you had to pick to focus on one, focusing on the sleep might result in improvements in the anxiety. Sometimes it's the other way around. If the person is having trouble settling to sleep because they're ruminating, then maybe your target is the anxiety. And if you can dial down the anxiety, then the ruminations go away and then they can fall asleep and stay asleep. So it may take understanding the nature of both the anxiety and the sleep disturbance in the individual. But if one had to pick one medicine as a first thing to do, usually we've gone with mirtazapine, we've gone with a low dose. Sometimes people have gone with quetiapine, Seroquel, also at a low dose.
Okay, thank you. Thank you. It sounds like it's kind of a chicken or egg moment with a lot of these things.
It can be a chicken or egg, and if you're not able to figure out which is which, then maybe one of those two medicines might be your starting point.
Excellent. I think this is a great question because, with a lot of different types of dementia, we see different types of symptoms. And so this is a healthcare provider who was asking, are there differences that we see in the psychiatric symptoms of Lewy body dementia and other types of dementia?
Oh, yes, absolutely. Now, if we're asking that for depression, anxiety, apathy, irritability, I would say the answer is no. They're about the same. But with the hallucinations and the delusions in particular, there are differences. So for example, Lewy body dementia, the first thing is in the timing. A person with Alzheimer's disease in general is not going to have hallucinations or delusions until they're fairly advanced in the illness. It's very rare that they'll have these in the beginning. With Lewy body dementia, it's typical that hallucinations, especially hallucinations, will occur in the beginning. When the hallucinations occur, they're usually visual. With Alzheimer's disease, they could be visual or auditory. With something like frontotemporal dementia, they're almost always auditory. But with Lewy body, it's visual hallucinations. It's formed, what we call formed visual hallucinations. Objects, animals, people, scenes, complex scenes, which is not typical for the others. People with Lewy body dementia also frequently have what we call reduplicative paramnesia. So that's a mouthful. But what it means is that they're duplicates of things. It could be a duplicate. They could be a duplicate of your husband or wife. The person in front of you could be labeled an imposter. You could be convinced you're in the house and you're also in the hospital. So these things are common. They can happen in Alzheimer's disease. Again, they'll be late, usually. But in GLB, they'll be early. The other thing that happens is what we call pareidolias, seeing objects within objects. If somebody sees a faces in the curtains, in colorful curtains, things like that, or sees an animal head in a lampshade, or mistakes a hedge for animals, for one animal or the other. That is almost always. That is something that you're generally only going to see in Lewy body dementia, unless you're seeing it, say, in Parkinson's disease. But compared to the other major neurodegenerative dementias, this is unique, almost unique to Lewy body dementia. The last thing that I'll mention are delusions of presence, the idea that there's someone there, that there are people in that house, or what some people will term phantom boarders. They're convinced there's someone else in the home, even though they don't see them. These things are quite common, and they're quite early. In Lewy body dementia, the descriptions tend to be very detailed. They tend to be rich. In Alzheimer's disease, it's someone stole my wallet, someone ate my food, someone puts too much salt in the food. It's very simple. In Lewy body dementia, you can have a whole story with a lot of characters.
Yes. Yes. A friend of mine who has Parkinson's disease dementia had a very vivid story about how the construction workers outside were pumping psychedelic drugs through the ventilation system of his home, how that was working, what the drugs were. So, absolutely.
Yeah.
Yeah, very different. You mentioned that reduplicative paramnesia.
Mhm.
So I think you're psychic because someone had a question. Actually, we've had a couple of questions come in about that.
Yes.
And so when, they're seeing that duplicate of them or their house, how should they respond to that? Like how should you handle that?
It's a very tough one. And logic seems not to apply. It's very difficult to get them to accept this. And it's not a surprise if one understands the biology of this. There are parts of the brain that have to do with familiarity. And, so if those regions are impaired, then a person struggles to recognize a familiar person as the real person, or to recognize a familiar place as the real place. And so people have looked at that. Then there's also the regions of the brain that have to do with spatial location that are also affected. And so there's some interaction between those regions of the brain that have to do with that imbue a thing with personal significance, or that endow it with familiarity, and that recognize locations. And the impairments have been linked to these regions when people have studied reduplicative paramnesia. So trying to debate it is not helpful, because the biological regions that will allow them to use that information are impaired. Also, the regions of the brain that have to do with logic. Providing reassurance, letting them know they're safe, maybe even with some touch to let them know you're there and that you're not going anywhere. Sometimes distraction can help, in the ways that we've discussed. Maybe even telling them, offering them a ride. But we've had a few patients that take a drive and they come back and now it's home. But until you step out that door and go somewhere and come back, it won't be home. They won't be home. They'll keep arguing that you need to take them home. So some creativity married to distraction and reassurance, I think, helps. Medicines we prescribe, and they can help sometimes, but sometimes it takes trial and error to get to something that makes a difference.
Yeah, for sure. And you guys, if you want to think of me in a very stressful situation, when I was a student at Mayo doing my clinicals, I had my first patient ever with Lewy, and he had misidentification strongly. Everyone he saw, he thought he knew them, and then he'd get very upset when they didn't respond to him. And I ended up with him one day. I had him in a wheelchair, and he put his feet up on the door frame because I was not leaving. He was going to talk to George. So I've seen this. It was like I could not argue him out of it. There was nothing I was going to do. I had to try to find a way to distract. And oh, look, I think we see, your wife down the hall, or something, because it was there was no room for argument. He knew this person, and that's all there was to it.
Yeah.
Yes, absolutely. Another question I think that comes to mind with this, around this like misidentification and reduplicative paramnesia, are the difference between like when it's an illusion and when it's a hallucination. So
Yes.
can you kind of tease those out for us?
So that can be difficult to, yeah, that distinction can be difficult to appreciate or even to establish. We would say it's a hallucination if the person is experiencing it and can provide a description that allows us to see that they're experiencing it as if the real object were there. There was something specifically there. When it's an illusion, usually it's not that vivid, and it might be something that's grafted onto some other object, so almost like a pareidolia, but not quite. So illusions, the person thinks that they see, but when they look more closely, there's nothing there. Or they think they recognize something, but when they look more closely, they see that they don't. They can get corrected, just by scrutinizing it or by being prompted to scrutinize it. With a hallucination, it's real. You're there, and so is George, to use your example.
Excellent. Thank you. So and one here that I kind of switches into mood when talking about that. And I think there can be a lot of variance, in the answer to this question, but this individual was told by a psychiatrist who diagnosed them that psychotherapy would not help someone with Lewy body dementia. And then in the presentation that we have on the Lewy Learning Center, she does, talk about, for some people that can be helpful. So can you kind of speak to that, and then what kind of, help should they look for, or psychotherapy would be helpful?
So psychotherapy is a broad term. So if someone would say that psychotherapy is not helpful, I don't know the context in which this question is set. The role of psychotherapy, firstly, can be to help a person cope with what they have. So if a person has insight, they can benefit for psychotherapy, particularly if the psychotherapy is focused on the here and now. Now, if it's psychotherapy where you're trying to get them to go back to various periods of their life and reflect and try to draw meaning from that to cast upon current circumstances, maybe that may be asking too much, depending on, and that's not psychotherapy that is focused on Lewy body dementia. That's psychotherapy that is focused on, coming to terms where you are in life. That's different. But for the purpose of helping people see that life can be lived, you might still be able to take things from your life. You can still participate effectively in your life, even under difficult circumstances. I think that can be helpful, particularly for people who have sufficient insight and sufficient memory, to draw benefit from that. So I would not say that it's not useful at all. Now, the other thing about psychotherapy is that it's the target might not necessarily be the person who has the condition. It can also be the two people together to help untangle. You know, sometimes the person has dementia and the caregiver is having difficulty figuring out how to relate to them in this new circumstance. And so the psychotherapy can help them both together develop new communication styles that make caregiving more effective. So when you say psychotherapy, it's not just for the patient. There's a caregiver involved. There's a dyad. And sometimes the target of the psychotherapy could actually be the caregiver, to help them come, shore up their own coping so that they can then have the wherewithal emotionally to cope, to care for someone else. When we now get more behavioral, we once had a patient, this is frontotemporal dementia, but it illustrates the point. He would go and rock the neighborhood cars and set off the alarms. And so you can imagine that, and he was doing this late in the evening, and the neighborhood was in an uproar, and people would try to get him to stop, but he wouldn't, because he had to check the suspensions. And so he's in clinic, and they say, well, I understand you need to check the suspensions, but your methods are crude, they're old. These are the old ways of doing it. And he says, what do you mean? I said, well, you need a checklist. Here's a checklist. He said, what is a checklist? All right, sit down, let's go over it. Well, you look at the tire, then you go around and you look at the other tire, then you look under the tire. And basically the checklist had nothing to do with touching the car. And so he still has the compulsion. He's still going out from car to car, inspecting suspensions, but he's no longer rocking the cars. So people think of, sometimes we call it behavioral therapy rather than psychotherapy, but it is a form of therapy. And it can help. So you can redirect dysfunctional behavior such that they no longer are annoying, even if the core symptom, in this case, compulsion, persists.
Excellent. Excellent. Thank you. Let's see. I've got one more question here that we got before the event today, and then we'll start to take a few of the live questions that we've gotten too. And I've kind of been weaving some of those into existing questions as well.
Yes.
So this one is regarding Rexulti. So their loved one experienced worsening psychosis from taking Rexulti. What would be safer alternatives to that drug? And I guess, what does that drug do too?
So Rexulti is a neuroleptic. It's related to Abilify. These are medicines that were designed for schizophrenia, similar to most of the other major neuroleptics. Now, they're frequently advertised as good for bipolar disorder. They're advertised as second-generation neuroleptics that will not cause Parkinsonism and such, but nothing could be further from the truth. Now, the unfortunate thing about Rexulti, which is brexpiprazole, and its sibling aripiprazole, which is Abilify, is that they cause the same problems as haloperidol. They just do it gradually. And so you're congratulating yourself on a person who is calm, and then 6 weeks later, they're stiff. They can't move, and they're confused. And so these are slow, long-acting. That's why this comes on late, and it takes a long time to reverse. We don't prescribe them. They're on the prohibited list, even though, obviously, when we put out educational materials, we can't write every single medication down. And so if you look at, for example, resources that the Lewy Body Association provides, you'll see that the medicines, and for those of you who are physicians, professionals, the Lewy Diamond Toolkit makes this very clear. There are medications, rather than try to write a laundry list of what is prescribed, we write a laundry list of things that are recommended. Clozapine is very difficult to use, but safe in terms of of a sensitivity. It's difficult to use in part because of regulatory issues that have to do with its effects on blood cells. Quetiapine or Seroquel is probably the place to start if you have to prescribe a neuroleptic, and if you are not going to prescribe that, pimavanserin is the next best thing. Now, the reason we wouldn't say Seroquel or pimavanserin is that pimavanserin has some insurance restrictions. It's far more expensive. Otherwise, it's one or the other. And if neither of those are effective, clozapine is more potent, but also carries more but also carries a regulatory burden, and it actually causes more adverse effects. So.
Thank you. And you guys, Rose will pop in the chat that Diamond Lewy management toolkit, and you can share that with your medical providers if you feel like, you know, they need a little bit more of a resource for the appropriate medications. For healthcare providers out there, this kind of gives you a cheat sheet, or
Mhm.
like I like to call it, the naughty and nice list, kind of the ones to avoid and the ones that are more appropriate. So, all right. Um, let's take some of the questions that we've gotten here during the event then. So going all the way up to the top, we've gotten a lot. How about sundowning? Is that common in Lewy body dementia, and how can you deal with that?
Very common. Firstly, with sundowning is essentially confusion that comes on later in the day that makes the person seem to be worse than they were, say, in the morning and in the afternoon. Having better sleep helps if they're having sleep troubles. But if at the time that they're in the sundowning, the thing to do is basically reorient them to reality, provide reassurance, speak in a calming voice, let them know you're there, using touch in the right ways, to remind them that you're there and that you care. That's the thing to do. Occasionally, if it's frequently complicated by agitation, we might find that we are in a position of having to prescribe something. But in general, reassurance and reorientation should suffice.
Excellent. Thank you. Thank you. So we had a question here too. Are there any non-drug approaches that you can use for these psychiatric symptoms? Anything that doesn't involve medications?
Yeah, so we've talked about reassurance, we've talked about use of touch, we've talked about avoiding debate and using distraction. And in the example about the gentleman with the car, I gave an example of more formalized approaches where you redirect a behavior, dysfunctional behavior, in a way that makes it less annoying. There are formalized approaches such as the DICE method or the ABC, antecedents, behavior, consequences, where you analyze the behavior and then you realize what came before, what happened, and then how that became a problem. And by understanding that process, you can see the environmental contributors to the problem, and you can take them away. One example is a gentleman who had attacked two nurses in residential care, and it turned out he'd done it a week before. And when you interrogated the problem, he was sleeping. He got up and then the nurses came to stop him from voiding in the hallway. On both occasions, he was voiding in the hallway in the middle of the night, which is unacceptable. They tried to stop him and he started fighting. And then in interrogating the behavior, it turned out he had been sleeping before. And what happens is right after dinner, he'd go to bed. He'd just go to his room and lie down and sleep. He had a bathroom in his room, mind you, but the light was off. And so the door to the hallway was open. And so he wakes up in the middle of the night and follows the light, and the light leads him to the hallway. So what's the environmental change to make? Check on him after dinner when he's asleep, turn on the lights in the bathroom and open that door, close the door to the hallway. And that was the end of the problem. So that's an example of antecedents, behavior, consequences. And there are many iterations. The DICE method is essentially the same thing, spelled out in a different way. But very often, a person who's living with a condition is not necessarily, when they're engaged in agitation, they may actually be reacting appropriately, but it's because they've misinterpreted the environment or what is happening. And if you can understand that, you can alter the environment or alter the interaction.
Absolutely.
Very helpful.
Yes, and a lot of times this can involve and get into different activity prescriptions too. So making sure that the person has things to do, kind of those distractions that Chiadi was talking about. As an OT, that was something that was in my wheelhouse. So it's finding the right distraction at the right time.
Absolutely. And
Absolutely.
even just structuring the day so that they have constant activity and make sure they have a regular sleep schedule at night, because sleep is another problem. And often we prescribe for sleep, but just having good activity through the day and keeping them up and active so that they're not falling asleep in front of the TV in the middle of the day, that can help.
Exactly. Because a lot can, and I know you see this too, their night times and daytimes can get switched around, and that
Yeah,
can cause a
yeah.
lot of problems for sure.
Mhm.
A really great question here, I think, about general anesthesia. Is that always problematic for patients with Lewy?
It can be, depends on what anesthetic agent is used. There are anesthetic agents that might cause confusion immediately. For example, with eye surgery, you have to dilate the eye. If you use atropine, if they use atropine to dilate the eye, that can set off serious confusion, and that confusion can come with agitation and fear because, so if they having a prior discussion, sometimes I have a prior discussion with surgeons. If they have questions or if the family has raised the question and we have a conversation, we get clear about what the anesthetic agents are. Now, it may be unavoidable. You have to do, if you're going to have to do major surgery, you're going to have to use anesthesia. So there's an immediate post-operative period where confusion can be expected and it should clear. And maybe the thing to do is just to let the people know, the people who will be looking after that person in the immediate post-operative period, please restart their medicines as soon as you can. And just be mindful that they might be more confused than the average person. And also make sure that pain control is properly addressed. And I think once people are prepared and it's sufficiently informed, it can go well, even if there's confusion in that immediate post-operative period. Thereafter, people should be fine. I know that there's a lot of talk about anesthesia making things worse. That's not what we see. There's a dip because of the drugs that have to be used in that process, and then once those wear, people return to where they should be.
That makes a lot of sense. That makes a lot of sense. But I know that it can sometimes seem correlated, I'm sure, for people. A question here that actually I had a friend or a patient who actually experienced this. So she said her husband just had two very bad panic attacks and tried getting out of their moving car. Is that common with Libby?
I wouldn't call it, it's not common, but it's not something that's unheard of either. I've heard it a number of times, people getting frightened and trying to get out of the car when it's moving. One thing in general that is prudent to do, even if a person has dementia that's sufficiently advanced, it's prudent if you can to use the child locks and to have them in the back. Firstly, so they don't interfere with the steering wheel and such. Secondly, for this sort of issue, because sometimes even if they're not necessarily frightened, if you stop in traffic, they may think it's time to get up and reach for the door. And we've heard of that sometimes happening. So these are some simple precautions one can take. But if they're actually in the scenario that you described in the question, that's something that probably means that they need to be treated for anxiety, that the changing scenery as the car is moving is probably discombobulating.
Yes.
And treating the underlying anxiety, maybe minimizing the transportation might help.
I even had a patient at one point with Parkinson's who had severe visuospatial deficits, and she would get very anxious because she thought that the other cars were going to hit them. So
Mhm.
she resulted to wearing, she wasn't driving, her spouse was driving, wearing like a sleep mask
Mhm.
over her eyes just because she really could not perceive and would get really upset. And she found it was just best for her to turn some music on or a meditation app and take her vision out of it when they had to go somewhere. And I know that can be a little awkward, but there can be a lot of reasons I think that someone might have that reaction or have some of those fear-based reactions in a car.
I'm going to
Um,
write that down. That's a clever intervention. Just cut out the visual stimulation for the time being. Or
yeah,
use
yeah,
music to distract them in your headphones.
yeah. She said that was the only way she could do it. Otherwise, she would get so upset because she was convinced everyone was going to hit them.
Yeah.
So yeah. Another question here about someone diagnosed with Alzheimer's in 2020, and now they've been diagnosed with a co-pathology of LBD in 2023. And so they've begun to verbally kind of create their own reality. So I'm assuming some confabulation. Is this the beginning of hallucinations or part of the Alzheimer's? Or is it possible to tell?
Well, it's difficult to tell. Firstly, I know, with the constraint of the way we're doing this, there's not enough information for full context. Um, so for example, we don't know if they have delusion, if this is happening because they have delusions at the beginning, or if it's just confabulations. But linking it to Alzheimer's or Lewy body dementia will be difficult to do in this situation. What I will say is that co-pathology is actually quite common, especially in older people. When you start getting to 80s and 70s and 80s, it's not uncommon for people to have co-pathology, and Lewy body dementia AD co-pathology is common. And sometimes we see it, we have reason to suspect it if people with Alzheimer's disease develop hallucinations earlier than we would ordinarily anticipate, or if those hallucinations are more vivid than we would ordinarily anticipate, or if they develop Parkinsonism earlier than we would ordinarily expect. And we've had a few cases where we had that suspicion, and it was borne out when we did a postmortem brain examination.
And I think this is something we're really starting to learn more about in the science. It's relatively new. I think this understanding of kind of not that there is co-pathology, but how, like, what that presents like clinically.
Yes.
Um, that was a hot topic at the Alzheimer's Association conference this year for sure.
The development of biomarkers of, the ability now to image amyloid and tau in the brain. And in time, I think we're not that far off from being able to image alpha-synuclein in the brain, which would allow us to use brain scans to confirm a diagnosis of LBD, even if people are very early. When we get to that point, we might be able to start to do the studies where we can see when the co-pathologist joins the process and what new symptoms accompany it. And I think that will really advance the science.
Absolutely. I'm going to let that be the last word. We've gotten some amazing questions, you all, so many. Thank you so much for your time today. But unfortunately, we're out of time. And I want to thank you, Dr. Onyike. Everybody give him a warm thank you using your reactions down at the bottom for his time and expertise. That was just such a great session. So many excellent questions. On behalf of the Lewy Body Dementia Association, I want to thank you all for joining us today. And as a reminder, you're going to receive an email in about 1 week with the link for the recording of the presentation. And we'll be including a lot of those resources that we talked about today, like the Diamond Lewy Management Toolkit. I'll try to throw some stuff in there about the DICE method so you can check that out, our medical alert card, and also any other links that Rose shared with you. We invite you to that new landing page so that you can register for upcoming webinars. November is National Family Caregivers Month. So visit our website and keep an eye out on your email for lots of special events and educational resources. Our next webinar will be on Thursday, November 7th at 1 p.m. Eastern Time. It's going to be myself and Brandy Hackett, our Director of Support Services, talking about how the journey is really different for care partners of people with Lewy than other types of dementia. And finally, please take a moment to complete that survey that's going to launch when you leave to help inform our content. And I will see you soon. Thank you again, Dr. Onyike, and thank you all for joining.
Thank you. Thank you all for having me.
Absolutely.
And I saw the special effects with all the love, so I appreciate it. Thank you.